Mhm.
Okay, so today Timur is going to share with you the whole presentation that he has on uh, assessment and treatment of suicidality, depression, all of these very important topics, and I'll let him introduce himself.
Yes, first I would like to know if you see my screen.
Yeah, we
You
see.
see my presentation.
Yes.
Okay, great.
Yes, we see.
So, hello everyone. I'm glad that we are such a small group, so we can make this lecture interactive. So we have 1 hour together, and I hope to be able to introduce you into the basics and really most important aspects of one of the most important mental health topics, suicidality and suicide. I am general practitioner and psychiatrist, currently based in Basel, Switzerland, and I'm also a passionate logotherapist. I've done my training with Batya, and I'm really glad and I'm really honored that I can stay engaged and stay connected to the institute and teach every now and then. And to all trainees, I can like really tell, no matter in which helping profession you are, whether you're a doctor, social worker, nurse, whatever, in my opinion, logotherapy really does enrich your perspective and your daily practice and will benefit your clients a great deal. And this is my personal experience every single day. So, the learning objectives for today, I would like to teach definitions of key terms related to suicidality and self-injurious behavior. I would like you to take away the main risk factors and warning signs for suicide, procedures to follow when suspecting suicidality, the most important elements of communication with suicidal patients, and the most important treatment measures or interventions. So you might have heard, even if you don't have a mental health background, about those two terms, and they are frequently confused. What is suicidality? What is suicide? Suicidality is the umbrella term. It encompasses all self-harming thoughts and behaviors and includes suicidal ideation, so thinking, brooding about taking your own life, and suicide attempts, unsuccessful and successful ones. While suicide refers to self-inflicted death as a response to life crises or states of suffering. On an epidemiological scale, and I like to start as is typical in medicine with basic epidemiology, you see this is not a niche or marginal phenomenon, but suicidal death by suicide is really very common. It's currently estimated that more than 700,000 people worldwide die each year by suicide. Um, that's about 1 in 100 people who die each year. Um, and in some groups, such as younger people, for example, it's the second leading cause of death after unintentional injuries. The interesting thing is, and here you see how medicine, psychiatry, and culture is interwoven, culture and economics, of course. The suicide rate, so how many people per unit of inhabitants die by suicide each year, varies widely by country. And notably, the country which has now for years the highest suicide rate in the world is South Korea. You see that Europe, North America, Switzerland are somewhere in the middle. Israel is famous for a relatively low suicide rate, which is also pretty stable for the past 20 years. And the nation that authentically records suicidal events and has notably the lowest suicide rate in the world recorded is the small Caribbean island nation of Antigua and Barbuda, where it's virtually non-existent. In the United States, for example, and I will frequently refer to the US healthcare system since because simply of its wide influence and dominance. We see that while many or deaths from some of the most common and some most important diseases, such as respiratory diseases, cancers, have been in decline for the past years, death by suicide is among the ones that is actually increasing. You've probably, if you are working with people with mental health problems, you've seen this probably before. These multiple parallel scars, which can be on the forearm, which can be vertical or horizontal. That's usually not necessarily a sign of a survived suicide attempt. This is often non-suicidal self-injury. The mood for it is different. People usually do it to regulate intense emotions that they experience as intolerable. Then the question is, and I think this is interesting for you if you're working with different age groups, when does suicide actually start? There is really no absolute age limit, and in the very few cases, suicide attempts have been even observed before the age of 10 or before the age of 6, even probably. But it really becomes a more common phenomenon from the age of about 12 on. And this is also the age where the widely known gap between men and women starts developing. And men have a higher risk of dying by suicide compared to women. This is also frequently confused because women have a higher rate of suicide attempts, but men still die more frequently from it because they tend to choose like harder or more violent suicide methods. It was previously believed that about 90% of suicides are related to mental disorders. This is probably overestimated, and suicide can be a dysfunctional coping reaction to stressful events. It doesn't necessarily have to be linked to a mental disorder, and suicide itself is also not classified as a mental disorder. However, the link is frequent and approximately, and this is very important to remember, very important practically, approximately 50% of all suicides occur during a depressive episode. And of course, suicide is such a major public health concern, not only because it affects the suffering individual, but it has ripple effects on their families, caregivers, and the wider community. This man, Edwin Schneidman, is considered the father of modern suicide research. And he stated something important in the 1980s, which I argue is valid until today. He argues that currently the major bottleneck in suicide prevention is not remediation, so treatment, for there are fairly well-known effective treatments and procedures for many types of suicidal states. Rather, it is in diagnosis and identification. And this is why we are placing the emphasis in this presentation on precisely this. And it really requires some attunement and attention to it, but it is really not hard. I think before we make up our mind to intervene, I think it's important that we clarify for ourselves, is there such a thing as rational suicide and the right to die? Is it a reality or a myth? It's important to understand that suicide is mostly a result of unbearable psychological pain, hurt, anguish, soreness, and aching. Schneidman called this psychache, psychological mental pain. And he theorized that unresolved psychache results in suicidal behavior. Psychache stems from a thwarted or distorted psychological need, and every suicidal act reflects some specific unfulfilled psychological need and a desperate attempt at a solution of a problem. And modern neuroscience research actually shows that psychological pain, psychache, is more than just a metaphor. But we see that the same brain areas that are responsible for processing physical pain are also involved in experiencing mental pain. So a person is quite literally in a state of unbearable or is unbearable experienced pain. For a suicide attempt, one must overcome survival instincts, which are, of course, very strong in most people. It is an acute state comparable to other medical crises. It's really an emergency state, like a heart attack. This point is reached when psychological pain becomes unbearable. And indeed, these are rare and valuable neuroscience results. People with suicidal thoughts do show an altered brain activity. Um, is there somebody who has like a medical biology background? Okay, so what we see, if you see this, where I put the circle, oh, sorry, this green activation pattern. So that's a state of activity. And you see the participants were instructed. These are participants who suffered mostly from depression and recurrent suicidal thoughts. And they were instructed, or a trigger was provided that typically triggered suicidal thoughts. And this is an MRI scan, and they were scanned in a more relaxed state and then in a state with triggered suicidal ideation. And we see that in this moment, there is a tendency toward a shutdown, so reduced activity of this brain area, which is called the prefrontal cortex. And the prefrontal cortex, that's the main area where judgment, planning, rational decision making is processed. So we see that people are temporarily in a state of quite literally dysfunctional or severely limited ability of judgment and decision making. And this brings us to a very important realization, a very important term when discussing suicide: impulsivity. Suicide attempts are most often impulsive. And we know, and these are very valuable glimpses from research with suicide attempt survivors. And research with those people shows that most report that, so 24% in some studies of people who survived a suicide attempt decided within the last 5 minutes before the attempt actually happened. And 80% of those affected denied suicidal intentions during the last doctor's visit. The desire to die is rarely unequivocal, and the wish for suicide is extremely rarely irreversible. And again, we know from data from cohorts of suicide attempt survivors that during hospital treatment, up to 80% report that they have abandoned suicidal intentions during inpatient treatment after a suicide attempt, only 2 days. And within less than 10 days, more than 90% of people report that they have abandoned suicidal intentions. So you see, it's far from being irreversible, it's very quickly reversible. And many people don't understand how could they be so desperate? How could they arrive at a point where they are willing and ready to make such a choice? And we also know when suicide is linked to a mental disorder, then the best predictor, most favorable predictor of remission of suicidality is successful treatment. And this is data that shows that patients with major depressive disorder, major depressive episode, suicidality basically disappears. It's strongly reduced upon partial treatment response, and it's basically non-existent with full response, which is remission. So a very important takeaway message so far is that suicide is preventable. Many affected individuals want to live, but simply see no solutions to their problem at hand. And those affected are almost always ambivalent. Very important, another very important word in the context of suicide, ambivalence. Most are ambivalent until the end.
Can I ask a question or not yet?
Yes, please.
Yeah. What kinds of problems are the most prevalent that they don't see a solution to?
Financial ruin, for example, a
Mm,
breakup of a relationship, medical health problems, job loss, severe mental illness.
mm,
These are the typical ones. Of course, psychologists are trying to decode and describe the suicidal mind, and there are typical cognitive patterns that are usually found in people struggling with suicide. What stands out, and these are not necessarily stable, they can be, but are not necessarily stable traits over a lifetime, but they can be characteristic in a certain episode in life. Dichotomous thinking, for example. Either my partner is going to stay or they're going to leave me and then my life has become worthless. Either or, there's nothing in between. Like cognitive rigidity, something has to be. I have to, I gotta have a certain achievement at a certain age in my life, or otherwise I have failed as a person. Attentional bias, attentional fixation, like an over fixation on a given problem. That combined and amplifies decreased problem solving, which leads to hopelessness and a pain which is experienced as intolerable, interminable, and inescapable. And this increases the suicide risk enormously. And Schneidman, again, classical theory, still valid, still important. He proposed that people basically suffer from a narrowing of mind or narrowing of perspective or consciousness. A person with extreme psychic and extreme mental pain sees only one solution to their problem, which is suicide. And the task of the therapist or the counselor in the course is to stepwise and gently contribute to broaden their perspective and escape this narrowing of consciousness. And people might, or usually most people have one or several other options which are viable long term. And it's very important to identify those resources and help people to activate them. Other options, and this is, of course, not complete, are mindfulness and acceptance, healthy lifestyle choices, self-care, value-oriented living, support opportunities, treatment if a mental illness is involved, activating your social network, orientation toward the future, and one thing that we must not forget, simply time. Because pain, which is an experience is unbearable, is rarely unlimited. Pain, be it bodily experienced or mentally experienced pain, really there are only two categories. It's either very intense and then it's usually short-lived. The pain declines quickly. Or it's chronic, but then it's usually low grade and manageable. Suicide is something that affects certain professions disproportionately, and generally helping professions are more affected, including social workers, psychologists, educators, but also doctors. And doctors have a noticeably high suicide rate. And this is also really interesting. This is one of the few subgroups where women have a higher rate of completed suicides. And the numbers are really staggering. Up to 400 physicians die by suicide each year in the US. So an entire graduation class in medical school is just choosing to die every year. Really disturbing. One reason why this and other groups might have an increased risk um, despite probably more resources is stigma. And suicide is, of course, still highly stigmatized. It varies by country. And rather than preventing or holding people back from choosing it, stigma actually increases isolation and the perception that it's inescapable and increases the risk. And of course, the stigma of having suicidal thoughts, behaviors, or being related to someone who is affected, for example, suffering a loss by suicide in the family, they are all independently burdened by stigma, but it's of course compounded by the stigma against mental illness itself. And it's really important to overcome it. What are the most important risk factors for suicidal behavior? Mental health, but not limited to it. Physical health, especially chronic pain. History of mental illness and suicide. So this is the single greatest predictor if someone will attempt suicide, past suicide attempts, prolonged stress, a history of trauma, very important, and very practical, simply access to lethal means. Child abuse, for example, is widespread and a strong risk factor for suicide. We see repeatedly in empirical studies published on the topic that a history of trauma, and it doesn't necessarily even have to be overt, visible trauma, such as physical or sexual abuse, but more subtle forms like chronic neglect or invalidation by a caregiver or your family um, can also increase a person's lifetime risk. And of course, there are certain particularly vulnerable groups. Ironically, doctors are among them. But for example, LGBTQ youth have a noticeably increased risk because of compounding risk factors. Of course, in medicine and biology, we are working with these models that are trying to explain how does a phenomenon like suicide emerge and how are those risk factors interacting and accumulating in suicidal behavior. Family history, very important. Early life adversity, strong predictor. It's believed, and this is now a purely psychological, of course, purely biological view. Of course, there are not only biological predictors, but it's really a complex web of social, psychological, and biological factors. But purely from a biological point of view, there is strong evidence that epigenetic regulation, so basically it's a biological mechanism which decides which of your genes are translated into proteins and which are not. How does the body actually translate the genome into actuality? That might translate into developmental regulation of behavioral and emotional traits which are dysfunctional, such as increased anxiety, increased impulsive aggression, chronic substance use. All of those factors, especially when paired with stressful life events, increase a person's suicide risk. And this is a very important concept which informs clinical practice. All of this is, of course, to be understood as a background, web of background risk factors. But they become relevant when current life events put a person under enormous stress. And for each and every person, it's different. But we must assume that for every individual, and this is like really not the suicidal or people with suicide risk and others, they are immune to it. It could never happen to them. Like this is the typical stigmatizing view. And I think it's really false. It's way more helpful to see it as a continuum. And every person has a different individual tipping point where we might experience suicidality. And when this individual point is reached, a person enters what some call the suicidal mode: intense pain, intense inattention, and narrowing of consciousness that I described. This is a highly vulnerable risk state, but it wouldn't, in most cases, wouldn't lead to death if a person wouldn't have lethal means. And we see, and you can do this with individual global countries, US states, cantons in Switzerland. If you take geographic units and the availability of firearms, you will see that there is always a strong correlation between the spread and availability of firearms in the community and the suicide rate. Also, in Switzerland, the cantons with the highest firearm distribution in the community have the highest suicide risk. And I showed you that in the past 15 years, the suicide rate in Switzerland has declined. And what's really interesting as a case study is that the suicide rate among women stayed low. It's really the suicide rate among men which decreased. And why is that? It's because of a change in law that restricts more than it used to be the case, that men were able or were even mandated, in fact, to keep their firearms after the end of military service. And really, this reduction of firearm availability by law saved many lives. And I think that this sort of natural experiment, if you want, also really disproves a common myth that if a person is determined to die by suicide, they will find a way, no matter the method. And this is really not true. Like certain methods are simply more deadly and more accessible, and firearms are an easy one. And if you take that away, then the person is indeed not determined to find something else, but is more likely to survive. Um, I will share my slides after the end of this presentation. I really recommend for those of you, unless of course you had stressful experiences with the topic suicide in the past and are sensitive. But if you're not, if you feel like calm and able to handle it, this is a really valuable, amazing contribution. It's a report of a suicide attempt survivor who jumped from exactly this bridge, the Golden Gate Bridge, which is a famous suicide hotspot. And I think this is really a precious first-person perspective where he details what brought him to this point, why did he choose that, and how relieved and how grateful he is that he survived, and how he thrives nowadays, that he has found an alternative and help. So how are we detecting, how are we recognizing people that are grappling with suicide? Most individuals at risk show clear warning signs. This is a really important realization. What are the warning signs? They are actually quite simple. Expressing thoughts of suicide, many people do it. By far, not everyone is secretive about it. People who report strong feelings of meaninglessness in life. And I think because such a person might seek a logotherapist, um, we are actually a group of practitioners who might be, there are no empirical studies on this, more likely to encounter clients who are suicidal. People who report being a burden to others, being a burden on the family, for example, that's a strong warning sign. Increased social withdrawal when people abandon their social networks. aggression, and especially inhibited aggression, if a person cannot act out, for example, against an abusive superior, increased alcohol or drug abuse, an experience of humiliation, very strong risk factor, hopelessness, despair, marked mood swings, and if you get the chance, maybe to talk to relatives, if a person is saying goodbye to others, which many people do. There is and you see, this is really a topic where there are many harmful, widespread myths. And a very important and particularly harmful myth is that asking about suicidality could provoke it. If I ask my client, then I might trigger it. So that's definitely not true. There's no empirical data to support that. In fact, we know that most people respond very positively to open questions about suicidal thoughts and answer honestly. Again, preconception that people are deceitful or secretive as a default. That's not true. It's an extremely relieving experience if there's an empathetic other who is willing to listen and offers help. So ask your clients slash patients openly, even with slight suspicion. And in my opinion, every intake, so an initial conversation, and even if you're not a clinician, therapist, clinician, counselor, in my opinion, the question about suicidal thoughts should always be a part of it as a standard. So, how do we approach a client who is suffering from suicidality? We build trust. And this is something which can be achieved even within one conversation. Explore the situation, lessen severe symptoms, leverage supportive individuals, for example, offering to call a relative or a trusted other, and apply, and even this can frequently be done within the first conversation, apply problem-solving approaches. So what are interactive changeable components? Past harm, self-harm, history of mental health issues, family history of suicide, past abuse or trauma, bereavement and loss, exposure to suicide in the past. Of course, these are not changeable. But what modifiable are relationship issues, physical health, social circumstances to a certain degree, substance use, mood and mental health, psychological pain, and access to means. These are all changeable factors, risk factors that we can address. I would like to caution you, if you are a psychiatrist or your client is seeing a psychiatrist or mental health provider, prescriber in parallel, um, do not think that using antidepressants is immediately effective against suicidality. There is no proven specific anti-suicidal effect, and any antidepressive effect is A, not guaranteed, and B, does not cure short term, but only long term, after usually at least 4 weeks. And in some people, and this is acknowledged and also part of every black box warning in the package, especially initially within the first days or first weeks, there may be an increased risk of suicide when taking antidepressants. So be careful if you have a client who only recently commenced antidepressants. Close monitoring is really essential. So how to help? Usually it requires, and this is more difficult for clinicians in a hectic hospital context. It's easier indeed in your private clinic or private practice. It usually requires from the practitioner an increased investment of time. And it's really important to communicate a sense of calm, that there is enough time and resources for this patient. It's really important. It's really important to be direct and talk openly. Don't be afraid that you might trigger suicidality by being open and honest. Listen attentively and allow expressions of feelings and accept the feelings. Don't be judgmental. Very important. Stay calm. Don't act shocked. Offer hope. This is allowed and helpful, but abstain from glib reassurance. Everything's going to be fine. Like, this is usually not helpful. Especially us as logotherapists, we might be inclined to lecture on the value of life. This has its place, but not in that situation. So an acutely suicidal person doesn't want to hear about the value of life, especially not in a shallow way. So we should be like really careful with this. And don't be afraid to take action. Explore a person's preferred suicide method. Does she or he have a gun at home or stockpiled pills, maybe like sedative psychiatric drugs? Can be lethal and overdose. You can ask this your client very directly and also ask or make a plan to remove it. Always, of course, with the permission of the client. You can, for example, suggest if a person is storing a gun, maybe you have a trusted friend in the neighborhood, family member, deposit the gun there for a while until you are better. Or bring the stockpiled pills to the next pharmacy, discard them. Very simple measures that can save a life. When we assess suicidality, it's really helpful to distinguish between those three stages. And you see them usually quite uniformly indeed. Explore if the client, quote unquote, only has thoughts about dying, or is there maybe also a plan? Like, someone is usually way less at risk if there are vague thoughts of, I wish I was never born, or I wish not to live anymore, but have no idea how they would take their own life. This person has a way lower risk compared to someone who wishes to die and has a plan. Okay, so maybe there are train rails nearby my home, and if I were to do it, I would just go there and throw myself there. Or I'm storing a gun at home, or I have, from last year, I secretly stockpiled pills. I would take them all at once. So this person has a way higher risk. And the highest risk, and this usually also is very hard to manage on an outpatient basis, if there's a clear intent. And many clients will tell you openly, if you explore calmly, non-judgmentally, they will tell you, yes, I do intend to kill myself. Like, this is the highest risk and usually requires introducing the client to a nearby emergency department or psychiatric hospital if there is one. In the minority of cases where a client might intend to deceive you, Franco has a very practical advice. He advises, ask two simple questions. Are you thinking about suicide? And if the answer is no, ask, why not? What gives your life meaning currently? What is holding you back? And someone who made up their mind to die by suicide will usually not immediately give a clear answer to the second question. You as a practitioner really must get help. And I assume, like most of you, as a counselor in your private practice or maybe in your home, you don't necessarily have a professional network in your place at hand. So really make sure that within the confines, of course, of the possible, like try to establish a support network for your client. Don't stay alone in this. Get help from other professionals or agencies. The simplest thing is advise to consult or use suicide crisis lines. And there are lists. For example, there's a Wikipedia link. you see a comprehensive list of all suicide crisis lines in each and every country. Other healthcare professionals, like, for example, the patient's GP, or ideally if the patient has a psychiatrist or psychotherapist. But it doesn't have to be a physician. It can be nurses, physician assistants, nearby hospitals, emergency departments, and many more. For minors, also school staff, for example. For students, college research staff, resource staff. So really, according to the patient's individual context. Exactly. Here I have linked this Wikipedia link for a comprehensive list of suicide crisis lines. And in many countries, we even have multiple, some very general and others for specialized groups, for example, Native Americans. This is just one example. In Switzerland, it's a very simple number. You can also advise, and if you're working with someone over several sessions who is suffering from suicidal thoughts, I think that this is something which can also be rehearsed. In Switzerland, for example, it's a very simple number. You can just dial 143 24/7. You have someone who will consult you if you're in a crisis. Also in Israel, very simple 1201. Every person can learn this by heart, I think. And like even in a crisis state, people can remember or they have it written down in an accessible way. For example, on a slip of paper in their wallet. This brings me already to my take-home messages. A person considering suicide may not ask for help, but it doesn't mean they don't need it. Suicide prevention begins with recognizing the warning signs, and this is the single most important step. Speaking openly about suicidal thoughts can save lives, and seek help as a caregiver, build a support network. Thank you very much. I'm looking forward to your questions and the discussion.
Okay, so Veronica has a question. Daniel has a question. Okay, let's take down the slides and we can see each other. Thank
Mhm.
you very much, Timur.
Yes.
Very good presentation.
Yes, Veronica, maybe you start.
Yeah.
Yeah, I have a question. So thank you so much for all the information. But I actually truly want to ask, like, there are so many assessments where, like I live in England, and in mental health sector, they ask, do you have a suicidal thought? And this is the most ridiculous question for me personally. I think I even asked once a consultant, I said, even if I would, do you think I would tell you that? Like, where is reality check? Like I know from my own self and from the people I know, like they would never tell that. They would just do that. You know what I mean? Like you have to read. So I don't think that the person can say honestly, like, you know what? And I have five men. Two of them were successful on this, and three happily they are alive today. And they didn't tell to anyone.
I think it really depends on the population and also the provider and client relationship. So my personal experience is very different. Uh, my clients really are quite open and grateful that they have a safe space where they can talk about it and find help.
Maybe it's different when you're just filling out a form or
Yeah,
when you
yeah,
already build
absolutely.
up a relationship.
Yes, this has to be like really, this has to happen within like a safe relationship. And it doesn't mean that it has to be, you have to really know the client very well. My personal experience is that you can like build this kind of initial trust and relationship. You can establish it within 15 minutes, really.
Mm, thank you.
But it
Okay,
really
I think
does.
Daniel was next, and then Sonia, and then Vladen.
I actually just clapped my hands, but
Oh,
no, but I have a lot of questions. Thank you so much, Timur. It was great, great presentation. So, so you mentioned that that a wish for suicide is irreversible. I
Rarely.
mean, is
No. It's rarely irreversible. It
ah
usually is reversible.
usually is reversible.
okay, good. Now I'm better. Okay, good. So, okay, another question. Are there any, I was just thinking maybe that also could be done. Could you, are there any life experience, positive life experience, like they're negative, but I'm talking about positive life experience that you can stimulate or generate uh, with the person in the person, and thereby um, create some kind of great benefit for him to make him closer to some recovery or to abandoning these thoughts. I mean,
Yes, yeah.
you do that.
Psychotherapy or counseling can do this quite successfully, actually.
Hmm.
It starts with very simple measures, like
Hmm.
really basic self-care and lifestyle practices. For example, getting enough sleep. Uh,
Hmm.
like people who achieve this level of mental pain are usually underslept, and frequently also as a direct result of the mental health condition, if they have one. So
Hmm.
simple bed hygiene, for example, regular bed times, um, enough enough hours of sleep. This can decrease the risk dramatically. Regular exercise,
Hmm.
healthy
Hmm.
diet. Like this is really just the basic, very basic measures. But
Hmm.
living like more complex and maybe also more time intense to achieve, trying to build a life where you live purposefully, have a thriving social networks, engage productively in the community. These are all
Hmm.
protective factors.
Yeah, yeah, I understand. May I ask another question, or we are
Sure, I think we have time.
restrained in
Yeah.
time, you know? Um, um, mm, you mentioned that once you reach suicidal mode or kind of tipping point, that it's like it's a slipping. You can't really go back, or it's very hard to stop this process.
It's harder to go back. Yeah,
Years ago to go back. So just I was just at when you were talking about that, I recalled A Man's Search for Meaning, and that Frankl was like observing that like so few people were um, who could withstand all these experience in the concentration camp. So I was thinking maybe these people, most of the people just reached this mode that they gave up. He described that they stopped eating, they lay in the bed, they just want a cigarette and that's it. They don't go to the bathroom. So maybe just they reach that, and then you can't really expect from them more. So is that something what will we can describe like that, and then we can basically then our task would be to not to prevent a patient reach that stage, definitely.
Mhm. I would say these are quite exceptional situations, and
Mm.
simply like this constant extreme stress of being imprisoned in a concentration or death camp. Um, that's a quite unusual situation, of course. So I think that
No, obviously, I'm not talking about that
we
specific
really would have to
situation
look at
only,
this.
but these that are kind of similar. Yeah.
Uh, we really would like we really would have to look at this group quite specifically. And I think
Mm,
it's somewhat separate from what I described, maybe elderly people with a, like really incurable condition such as progressed cancer, where all
mhm,
measures to alleviate intense physical pain um, have been exhausted.
mhm, I understand. Maybe last question about the as far as I know, a rate of and the number of countries where the assisted suicide and the euthanasia is
Mhm.
allowed is going up, especially in Europe.
Yes. Yeah.
So I wonder what you think about that, and related to that is the question how the I mean tradition, if you want, belief, I don't know, religion, tradition more affect as a background, like
Mhm.
and allowed all that, and how if you come from the tradition that life is not the most important thing, and you can decide not to have it, or then it's easier for people to
Yes.
to achieve that. So do.
Yes, there is also empirical research on that. And I think that what emerges is a more nuanced picture. It's not enough that your religious system just values life highly, or there is simply a suicide prohibition, like there is in most Abrahamic religions. This is not enough. Being religious is for most people a protective factor. This is established, but it's probably having a positive relationship with spiritual system, which is carrying you through life, and also positive relationships in your religious communities, and taking advantage of their support opportunities. It's not just the prohibition. We see also that there might be a subgroup of religious people who actually have a higher risk if they have an adverse relationship with their religion, if their relationship is dominated by fear or shame.
Mhm,
But it can be a valuable protective factor, yes.
mhm.
Oh, good question. Okay,
Thank you
we,
so
we don't have much time left, but I just want to quickly get to Sonia and Vladin.
Okay.
So, yeah.
All right. First, I was just going to say people being honest or talking about suicide, and at least here in the United States, seems to be people are fairly open talking about, like if you are maybe not on a form, but if you're talking to them in person, I feel like they're, whether it's friends or in a clinical standpoint, they're pretty open
Yeah,
about
yeah.
saying that if you ask them directly about talking about it. Um, so that might be a cultural thing. I don't know. Um, the other thing I wanted to mention is you said something about doctors having the one of the highest suicide rates, particularly female physicians, and you spoke of stigma being a reason, a causative factor. So, like, just from my personal experience, I feel like um, some of the causative factors might be, and I want to know what, the research says, is there's a lot of perfectionism among
Mm.
doctors, like very A-type people. Um, the career is, very perfectionism oriented. Like, of course, there's a lot of stigma about not making a mistake, which because your mistakes are very impactful.
Yeah.
And female physicians tend to try to balance a full-time career and family. So they
Mhm.
still take the chunk of the family responsibility. So I wonder if that has partly to do with why women are it's more common among female physicians. And
Mhm.
then physicians do have access, like they have access to drugs, they have access to means. So
Yes.
that could be a reason that they also it's more common. And then I think there's the added stress of like loss of reputation with lawsuits. Like I feel like more, not female, but more physicians tend to start to think about suicide when they're threatened, their reputation's threatened.
Yeah, definitely. I think you have answered most questions yourself, and like especially why are women disproportionately vulnerable? I think you named it. I think it's simply the multiple roles, and it's at times also conflicting roles, conflicting expectations, and also the
Mm,
fact that more frustrated, like more deprivation of reward. There was still bias. There is still misogyny in those workplaces.
yeah.
Um, and another thing is that both men and women also frequently experience harassment and violence from colleagues, but also from patients. But women are disproportionately, of course, affected.
Right. And then my last question had to do with also what Daniel was talking about, assisted suicide. From a medical perspective, I'm a physician in the United States. From a medical perspective, there are some, this is a very like gray area. So, but there are some cases where patients are going to have a prolonged course of anguish without, with a very almost a zero, less than 5% chance of long-term survival. And their course, whether it be a week or 6 months or a year, is full of just pain. They have metastatic disease throughout the body. They're going to have a lot of just physical pain. So I don't know how I feel. Like I'm on the fence about if somebody wants to choose to not go through that.
Yes. Yeah, I agree. I think it's morally highly complex. And I do think that it makes sense to treat it as somewhat separate or a special case
Mm,
among suicidal behaviors. Um, and I'm less concerned about people who have objectively um, really have arrived close
okay.
to life's completion, and it's about like ending otherwise incurable or untreatable anguish and pain, preserve maybe a sense of dignity.
Hmm.
That's different from what really worries me is that in
Right.
countries like Switzerland and especially the Netherlands,
Hmm.
increasingly people for supposedly terminal mental illnesses are
Hmm.
using those services.
Hmm.
And I think that here the complexity really multiplies. Because for me,
Yeah.
any mental disorder is treatable, curable until proven otherwise. And it's very, very difficult to prove otherwise. And it's like seeing also remarkable recovery stories
Yeah.
and considering how much lives like changing life context, the also the high likelihood of response to external factors, the high likelihood of change because of your personal maturation and development. I'm extremely cautious and extremely skeptical about like people, for example, in their 20s
Yeah.
receiving that because of a sole
Yeah.
diagnosis, solely on on the grounds of a diagnosis of personality disorder. In
Yeah.
my opinion, this is very different from an 80-year-old with terminal pancreatic cancer.
Yes. Okay.
Yeah.
Thank you.
Yeah. Thank you. Okay. One more. Do we have time for one more question from Vladin? Because he didn't have a chance to ask. Is that okay, Timur?
Yes.
Yes. Okay. Go ahead, Vladin.
Okay, I will be quick. I'm try. So thank you, Timur, very much for your presentation and the slides. So so the question was connected with these factors, these um, three these cases. So biological, psychological, and social. And I saw on one of the slides that the lowest suicide quote is in Israel.
What are
And
the laws?
Yes, Israel, and then Antigua and Barbuda.
Mhm.
So I suppose in Israel, because of the preserved traditional values, and in Barbuda and Antigua, they are like paradise country. Now I'm so, and there is lowest rate, and I'm questioning also what is important. So values to preserve or to have some environment that can give us a secure life and so
Mhm.
that was my question regard to that. And I saw on one of the slides the brain, this anatomy, and was that amygdala? And is it amygdala responsible for suicidal um, so uh, thoughts or suicide rate or something? I'm not sure. So I'm not good in no, neuroscience, and that was how neuroscience question. And I also can tell you that with confidence that I am working also in a hospital here in Germany, and many of my colleagues, not many, so but some of them, they have done the suicide, and most of them are with these medications like propofol, these anesthetics. And
Mhm.
because I'm a priest also in Netherlands, I also many Dutch people that they are coming to religious communities and there to find the meaning and the reason for life. Thank you very
Mhm.
much, and sorry for the long uh, questions or comment.
No, no, thank you. Interesting question. So maybe I will start with the neuroanatomy. I'm also not a neuroscientist, so it's very rudimentary what I've shown. And I think it's not necessary to understand suicide, but it is interesting and does complement our understanding. So I was focusing on the prefrontal cortex, but I think, of course, the amygdala can also be an important part of it. And it's mostly famous, of course, for being involved in anxiety and fear. And I think like those are strong emotions that can be part, but don't have to be a part of a person's psyche. So I think it plays an important role in some people, but probably not everyone. And the other question, like, what is it about a nation like Israel? And several factors, and I think the economy does play a big role here. Despite, of course, the recurring or ongoing conflicts, it's a country which is, in comparison, it's wealthy, has a strong social system, universal access to high quality healthcare, um, access to high quality, nutritious food, and like many indicators of quality of life, and generally very high quality of life. And I think that the religious or more generally value fabric of a society does play a big role. And I think that it being very unique and being, on the one hand, a wealthy and highly industrialized country, and at the same time, very traditional, where family, community, religious ties are very important. And I think that those are highly protective. People have a strong sense of meaning in life, many.
Okay.
And Antigua and Buddha, sorry, this uh, are you familiar? What is the reason the so low rate of suicide there?
Yes, I need to dig deeper into this. I
Yeah.
haven't done my homework on that, to be honest. I was just astonished by the low rate, but I can tell you specific reasons, to be honest.
Yeah. So let's
Thank
look that up.